Hello, welcome to this edition of Neurology's Video Journal Club. I'm Dennis Bourdette, Professor Emeritus in the Department of Neurology at Oregon Health and Sciences University, and was a founding director of OHSU's MS Center. I'm here today with Dr. Lindsey Wooliscroft, who's an assistant professor of neurology at OHSU and Associate Director of Research of the VA MS Center of Excellence. We're going to be talking to you about a paper that was published in Neurology in February of this year, entitled Direct Healthcare Costs Associated with Multiple Sclerosis, a Population-Based Cohort Study in British Columbia, Canada, 2001 to 2020. Before I turn this over to Lindsey, who'll tell you about the article, I wanted to briefly say a few things about multiple sclerosis and the current disease-modifying therapies. As I'm sure most of you know, multiple sclerosis is an inflammatory disease causing demyelination in the brain, spinal cord, and optic nerves. It's a common disease. It affects 1 in 600 people in Canada and the United States, and over 2.5 million people worldwide. It's also a very treatable disease now with the advent of disease-modifying therapies, or DMTs. And in the US, at least, there's over 20 FDA-approved therapies for MS, and they fall into 9 different categories based on their mechanism of action. These drugs vary in route of administration and their efficacy. And we, in general, talk about moderate efficacious therapies and high efficacy therapies, which include ocrelizumab and natalizumab. So, as we'll be hearing, the cost of care of MS is quite expensive and is driven largely by the disease-modifying therapies. So, Lindsey, can you tell us about this interesting paper?
Definitely can. Thank you, Dennis. The authors from the CanPro Co group, basically their objectives were to estimate the excess cost of MS in British Columbia, which is defined as the mean difference in direct medical costs between a patient with MS and match controls. And they wanted to evaluate the relative impact of inpatient, outpatient, and medication costs and the association of those with age, sex, and these components. So in order to do this, they looked at administrative health databases between 1997 and 2020, which captured medical records from all legal residents of British Columbia during this time period. They include patients who were over age 15 with MS, which was defined as those with 3 or more MS-related health claims, inpatient, outpatient, or DMT use within a 1-year period. They've published previously on this technique, and the positive predictive value for identifying MS cases is about 99%. They also needed about 2 years of follow-up. So the study period ultimately used these factors to identify patients and then measured the direct costs between the years 2001 and 2020. After they identified the MS patients, they matched these patients to those without MS by age, sex, and cohort entry date to about 5 other people. And then they looked at the DMT cost, and they divided the cohort into DMT users who had at least 1 DMT prescription within the study period, and then frequent DMT users, which had at least 3 DMT prescriptions per year, which ultimately ended up including some therapies like cladribine, alemtuzumab, and B-cell therapy, which we typically think of as being given a little bit less frequently. And then they compared these to non-DMT users. Notably, all medical costs were reported in 2020 Canadian dollars, even though the time frame they looked at was between the years of 2001 and 2020, and were adjusted for inflation. So for those that are listening from the United States, that's about 1.35 Canadian dollars to US dollars at that time frame. So regarding the results, they ultimately identified about 17,000 patients with MS, and those were matched to about 85,000 controls. And the average follow-up time was 12 years. They determined that the annual excess cost of MS per patient was about $6,800, with the main drivers being the cost of medication at 65%, followed by inpatient costs at 25%, and outpatient costs being about 10% of that total number. When they looked at the impact of sex, the excess cost of MS was about $644, higher for men than for women, which was mostly driven by inpatient costs. When they looked at the impact of age, they found that those 29 years old and younger had the highest excess costs at about $10,000 per year, compared with patients 60 years old or older who had the lowest excess cost at about $5,000 per year, which did seem to be driven by medication and inpatient costs. When they looked at the impact of disease-modifying therapies, the average annual excess cost of MS for DMT users was about $13,000, compared with about $3,500 in non-DMT users. Frequent DMT users, the annual excess cost of MS increased to about $24,800, and it seemed like the inpatient costs were highest for non-DMT users and the lowest for frequent DMT users. Another interesting aspect is that they looked at these trends across time, and they found that in the first year after an MS diagnosis, there was an initial spike in hospitalization cost, and then an increase in medication cost during the second year. By year 10 after diagnosis, inpatient costs increase, and then the cost of medications decrease. Now, Dennis, what do you think were the most interesting aspects of the results?
Well, first of all, this is a very well done study. There have been other studies from other countries, including the United States, Canada, and Western Europe, looking at the cost of care among MS patients. But this is particularly well done, given the longitudinal aspect of it, even though it was a retrospective study, and the large number of people with MS that were assessed, and the large control group. So I think it's a very well done study. Like other studies that have been performed on the cost of care of MS, the medication costs were about 65% of the excess cost, and that's very typical of studies on cost, with drugs really driving the cost of care up significantly. So that was of interest in confirming that in this well-done study. You mentioned, Lindsey, that hospitalization costs were higher amongst the patients that were not taking DMTs. Do you think there might be a relationship between that, or are there other possible explanations of that observation?
Certainly could be a driver. I mean, I think that we have the benefit of having really highly effective disease-modifying therapies now, and I feel like that has cut inpatient admission rates, and certainly I think could have an impact on those direct costs. What else did you find interesting about the paper?
Well, of course, it was interesting to see the cost of DMTs in Canada. As a neurologist practicing in the US, very well aware that the cost of DMTs for MS are considerably higher. And they mentioned that in the paper, comparing their cost with an average cost of about $36,000 per year for DMTs. The other thing that was of interest was the Canadian study didn't show an increase in the DMTs after correcting for inflation over time, whereas in the US, the increases each year of the cost of DMTs is always much faster than the rate of inflation. So not only are they able to, in Canada, keep the cost of the DMTs lower than here, but they're also able to keep the costs down from rising above the rate of inflation. Lindsey, Did you think there were any limitations to the study that we should talk about?
First, being a retrospective review, we have to consider how they identified the patients with MS and potential diagnostic misclassifications in the algorithm. I mean, I think overall, the way that they did it has been proven in other manuscripts to be a pretty solid way to identify those with MS. But it does leave some room for some misclassification, especially if we consider the high misdiagnosis rates of MS in general. And then second, I really wish we could have nailed down a bit into the disease phenotype, whether these were progressive or relapsing patients and how severe their disease was. That would have been interesting to look at the different direct care costs for those populations, especially when we consider the different disease courses. We also couldn't really account for a lot of the laboratory work, which we know we have to do pretty frequently for those on disease modifying therapy. So that cost may differ between treatment groups, but is likely higher for those with MS. And we couldn't look at the cost that's added by scans, like MRIs for routine surveillance or if we are suspecting a relapse. But just going back to the drug cost, why do you think that it is so much higher in the US than in places like Canada?
The obvious explanation is that Canada has a national healthcare system, and as part of that, they're able to negotiate prices for purchase of drugs, and because of the numbers of patients that are being treated, have a lot of leverage with regards to that. Whereas in the U.S., we don't have national healthcare generally. And many patients are on private insurance that the companies can negotiate often rebates in the U.S. For the drugs, but those savings aren't passed on to the patients. We do have two systems in the U.S. that may be a little bit more analogous to Canada. One of them is the Department of Veterans Affairs, which is able to negotiate for veterans with MS lower prices, and it's been those prices aren't readily available, but we are aware that they're considerably lower than the cost of the DMTs available to patients with private health insurance, and more analogous to Canada. Medicare is also a national healthcare system. They're able to negotiate some reductions in price, and those prices are more alike with Canada's than with the prices available to private health insurance. We talk a little bit more, Lindsey, about indirect costs, because those are difficult to measure, but are very important to our patients with MS.
Absolutely. I think that there was an article with Bruce Bebo as the main author in 2022, and they estimated the total indirect cost of MS, at least in a U.S. population, and estimated that to be about $21 billion in 2019, with about $16.8 billion of that to people with MS, and then about $4.2 billion to unpaid caregivers. So you can see that there's a big ripple effect for absenteeism and presentism and a whole bunch of other things that affect indirect costs for patients and their families. And it's estimated that the average indirect per capita cost was about $17,000 for people with MS only, and about $21,000 for people with MS and caregivers combined. So I think the disease has really big financial implications. But thinking about me as a neurologist, understanding that the cost of MS care is high, both here and in a lot of other countries, as we see in this Canadian article, how much do you think we should consider drug cost in MS care for our patients?
Well, sometimes we can think of the cost of care when it's coming out of the patient's pocket as a form of economic injury. I think as neurologists, we often think, well, the cost of drugs, the cost of care, not really our business because we can't control it. But we're the ones prescribing the medicines, which are the large driver of the cost. And we certainly can pay attention to that and might take that into consideration when prescribing drugs. So, for instance, ocrelizumab is now the most widely prescribed drug for MS. It's approved for not only relapsing MS, but for primary progressive MS. But the clinical trial of it was in a limited age range for people with progressive MS, a limited disability range. And I see it often being prescribed for older patients, much more disabled patients that have progressive MS. I think one can question whether that's good for the patient in terms of safety. We don't even know if it's effective. And certainly it causes economic harm both to the patient and to our healthcare system. So I think some consideration of costs are important. I know that when I'm staffing young residents who are treating MS patients, I often ask them what was the patient's insurance, and they usually have to quickly look at the top of the Epic line to see what at least their primary is, because if patients have private insurance, they may well be eligible for copay assistance from the company that makes the drug that you prescribe. But if they've got Medicare, they're not eligible for copay support. And even if they have Part D, there's considerable expense that they accrue if they're on a self-injectable oral medication. So I think paying some attention to the insurance plans that the patients are on and how they those insurance plans cover or don't cover various MS DMTs that we prescribe, and keep that in mind, because there is economic harm that we can create through prescribing a medicine that's not well covered by a given patient's insurance. And often that leads to them stopping the medicine and being off of medications and interfering with compliance.
But really elegantly, because I think that first and foremost, as neurologists, I think we're supposed to be good stewards of these therapies for our patients and making sure that they're feasible and that people can stick to the treatment plans that we create with them. And part of that is cost, unfortunately, for a lot of these MS medications, probably a growing number of neurologic medications. And I think that there is a secondary obligation to kind of really think about being good stewards of these medications that could potentially have other side effects, which may have moderate benefit, especially in those progressive populations, and thinking about the trials which they were conducted and providing reasonable expectations with patients can probably help them make better personal, medical, and economic choices for themselves, especially considering those high drug costs. So I think I would agree. And that might be a good jumping off point. I mean, what do you think should be some priorities for some future studies looking at direct or indirect cost of care for MS?
Well, the belief is that the early use of DMTs, at least in relapsing MS patients, will pay long-term dividends for the patient and even economic dividends. If the early therapy keeps them from becoming disabled, they'll be able to continue to work longer. We know from a number of studies that patients who lose the ability to ambulate, their cost of indirect costs of care rise significantly, places burdens on their spouses and families that are indirect costs. So I think demonstrating that early treatment actually lowers costs in terms of not only admissions, but also in terms of keeping the indirect costs, lowering the indirect costs, would be a good way of establishing that even if the drugs are expensive, they pay long-term benefits. I think we still need to consider the wisdom of using the currently available DMTs in treating a disabled older patients with progressive MS. It's not clear that they're beneficial, and that population are very beneficial. And it's going to be difficult for any minor benefit that would be achieved with that to pay long-term dividends in terms of slowing progression and lowering a patient's indirect costs, if you will. And so I think we need to really think about the use of those medicines in the older patients, and particularly those that are older and have progressive disease. What do you think about that?
No, I would agree. I mean, I think that not only from a cost perspective, but also from a care perspective, understanding like the nuances of who we should treat when and for how long are some of the biggest challenges that we have in clinic. And I think that a lot of the things that you spoke to would really help answer that. So I appreciate the groups that are already working on that as well.
Another area that I think would be useful is there are questions about whether anti-B cell therapy needs to be given at the frequency that it's being given at. So for ocrelizumab, the infusion is given every 6 months. There is some evidence, even from the follow-up of patients that were in clinical trials and then stopped the medication, that the positive effects of ocrelizumab last much longer than 6 months. So it's possible that the current recommendation of dosing every 6 months might be extended after 1 or 2 years, and that also would lead to a lowering of costs. And but one would have to establish that there's no lowering of benefit in terms of control of the MS. But it certainly seems from some studies that were done with ocrelizumab early, and also studies that have been done with a generic form of anti-B cell therapy that's not FDA approved for MS, but for other conditions, rituximab, that the benefits of that are much longer lasting than 6 months, particularly after a patient's been on therapy for 2 years. So that might be a way to achieve benefit and lower cost.
Well, do you have any other closing thoughts to add, Dennis?
No, I think this was a very good discussion, and I appreciate your participating in this. And I also would like to thank the American Academy of Neurology for sponsoring this, and for you as listeners. What about you? Do you have anything you'd like to close with?
No, echo all of that. Thank you so much for listening.